Please welcome to the stage Dr. Kristin Higgins, Dr. Debora Bruno, Dr. Stephen McCune, and Dr. Lynn Durham.
All right. Well, thank you, everyone. Thank you so much for attending our panel. I am Dr. Kristin Higgins. I am a radiation oncologist and the Chief Clinical Officer of City of Hope Atlanta, and I'm very excited to moderate our panel today entitled Women First, Collaborating for Better Cancer Care, Redefining Outcomes for the Next Generation. So I want to start by telling you a little bit about City of Hope Atlanta. At City of Hope Atlanta, we believe that cancer care should be as unique as the individual receiving it. We're located just outside of Atlanta in Noonan, Georgia, and expanding into Metro Atlanta this November. Our center is part of one of the largest and most advanced national institutions for cancer research and treatments, delivering trailblazing cures at life-saving speed. City of Hope started outside of Los Angeles, and we now have a national cancer footprint with institutions in Orange County, California, Phoenix, Chicago, and Atlanta. We are a top 10 cancer institute per U.S. News and World Report and a National Cancer Institute designated cancer center. We believe in bringing together leading research, precision medicine, and compassionate whole person care, all under one roof, making it easy for our patients. Our mission is simple but powerful: to deliver life-saving care with urgency, empathy, and innovation. That means that things like offering same-day consultations, rapid diagnostic results, and personalized treatment plans that reflect not just the science, but the values and goals of each patient. So as a physician and a woman, our topic today is something that I am passionate about. Young women facing cancer often encounter unique challenges, biologically, emotionally, and socially, from things like fertility preservation to career disruption, from body image to survivorship. Their needs are distinct and deserve to be addressed with intention and insight. So today we're going to hear from an incredible group of experts and leaders who are helping to reshape what cancer care looks like for younger women. I really hope that this conversation sparks new ideas, challenges our assumptions, and inspires us all to keep women at the center of the care that we provide. Through a collaborative approach, we can find the answers together. So let me introduce our panel. I want to start with Dr. Debora Bruno. Dr. Bruno is a medical oncologist and the medical director for clinical research at City of Hope. Second, we have Dr. Steve McCune. Dr. McCune is an oncology service line physician lead at Wellstar Health System, and he brings a systems-level perspective on care delivery. And then we have Lynn Durham. Lynn is the president and CEO of Georgia Core, a nonprofit champion for statewide oncology research and education. So really a powerhouse of people up here that all bring a unique perspective on this topic. So I'd like to provide some context for our panel today. We now know that women under 50 have cancer rates that are 82% higher than their male counterparts. This startling statistic was part of the American Cancer Society's annual report in 2025. We know that new therapies are allowing our patients to live longer, and it's great that we are achieving this success. But ultimately, the cancer research and treatment has been tailored towards older patients that have been historically more impacted by cancer. So now that we have this disparity with younger women having to deal with cancer at increased rates, we really need to rethink our approach to how we respond to cancers in young women. And so there's 3 areas today that we're going to focus our panel on. And we think that to really grasp at these challenges, we need to collaborate with all of the different organizations that focus on cancer care. But the first area is helping younger women understand their cancer risk. We are calling for wider availability of risk assessments for women, and this means things like genetic testing and lifestyle factors. I want to call out a really unique program by the American Cancer Society, Black Voices of Women. This is a study that American Cancer Society is conducting. They're trying to register over 100,000 women, Black women, ages 25 to 55, to understand what lifestyle risks could be contributing to cancer And this is a really unique program that I think will really tackle this area of risk. The second area we need to discuss today is clinical research. As I mentioned before, younger women are underrepresented in these clinical trials that are leading to novel therapies for cancer, and we really need to change that. And then the last topic is supportive care. At City of Hope, we believe in a national standard for supportive care. Supportive care means supporting the whole woman throughout her cancer journey. We need to focus on things like psychosocial support, fertility considerations, family life, workforce reemergence, and then how to manage the psychosocial aspects of dealing with a long-term risk of reoccurrence for decades after these women are treated. So as you can see, we have a lot to tackle during this panel. I want to start with Dr. Bruno for my first question. So Dr. Bruno, going back to risk, how can we empower women to understand their cancer risk? What do women need to know? What do they need to ask their doctors about or ask their family members about to understand what risk they have inherently?
Yeah, thank you, Kristin, for this question. First of all, I want to thank the team that organized this event. I'm thrilled to be here, sitting with such brilliant colleagues and discussing such an important topic, which is really delivering cancer care for a younger female population. So risk assessment is key, right? I mean, we live our lives gauging risk, planning according to the odds of outcomes. And when we look at our risk for developing cancer, this is not something that should be foreign to us. We should really think about our risk. And talking about the cancer rates rising in younger females nowadays in the United States, what's really driving that rise is breast cancer. Breast cancer is driving the higher rates of diagnosis for women younger than 50. Currently, the annual increase rates for breast cancer for women younger than 50 years old is 1.2% annually, and for women who are younger than 20 years old, 2.2%, so really alarming rates. So we all need to understand risk assessment, and that starts by looking at basically 4 pillars. Your personal history, your family history. We need to know our family histories, talk about cancer diagnosis. Cancer is typically a taboo. We don't talk about it. We don't want to know exactly what happened to our relatives, but we need to ask those questions. It's key we do that. Understand also if there is genetic testing that has been done in family members, perform genetic testing when it's necessary in ourselves, of course, and then look hardly at our lifestyle factors that may be contributing to an increased cancer risk. For breast cancer risk assessment, there are many models available out there that we can utilize. The Gale model being the most widely used, that basically helps you to plug in your characteristics and come up with a number that then helps you define how you should screen for breast cancer and if you should be worried about taking further steps in reducing your risk for developing the disease. So on average, for instance, women have a 12 to 13% lifetime risk for developing breast cancer, and that's 1 in 8 women will develop the disease in their lifetime. And for the average risk woman, the USPSTF and the American Cancer Society recommends starting screening at age 40, yearly screening with mammograms. But if you run such a model and you find yourself to have a higher risk for developing breast cancer, 20%, 25% or higher throughout your lifetime, you should probably start screening sooner, at age 30 or younger, and using other techniques that are just not mammograms, breast MRIs, for instance, in conjunction with mammograms. And then think about potentially risk-reducing strategies as well. So this is all very important to keep in mind, because really for breast cancer, risk assessment has to the capacity of research that has invested in that, being able to identify multiple factors that we can look at. For other cancers, however, lung cancer being one of them, where we're seeing also alarmingly increasing rates in younger females, women ages 30 to 49 are much more likely to develop lung cancer, even if they never smoked, compared to their male counterparts. We're still, I would say, at the beginning of the stages of understanding risk for those individuals, but we're going to get there through research, the research approach, collaboration. We'll get there when we start to have, the dream is to have really precise risk assessment tools for every cancer.
Thank you, Dr. Bruno. My next question is for Dr. McCune. How can health systems expand access to genetic testing and risk assessments? And what are the barriers and how do we overcome those?
Sure. And thank you. I appreciate the opportunity to talk today. First of all, let me mention, so I'm a medical oncologist with the Wellstar Health System. If you come see me for breast cancer, we're about 10 to 20 years too late. And so what we want to do is move the needle to identify people at high risk much earlier. We want to focus on prevention rather than treatment. And I think what Corwin Harper said this morning was fantastic as a charge to everyone at the meeting. Try to meet 5 people today that you don't know. Shake hands, just walk up to someone. This is about collaboration. This is about working together. We may compete in some ways as health systems, but there are so many people in Georgia who don't have access to care. That's what we really want to work on and reach out to people. I'll mention about 3 areas very quickly. And so I'm from Atlanta. I'm actually from East Point, Georgia. So I grew up here. I think I know some of the health access issues even within the Atlanta area, let alone areas in Georgia that are really far from a large health system. So really 3 things I want to focus on. First of all, let me mention Wellstar has a really excellent medical genetics program led by Kim King-Spawn, but they have 8 counselors, and there are 11 million people in Georgia. So that's less than 1 medical genetics counselor for a major health system per 1 million people. So we have to reach out in a different way. And I want to emphasize one of the things that Wellstar has done. So our CEO, Candace Saunders, is actually in the ballroom next door in a panel right now. But she's led Wellstar for 10 years and is focused on women's health. The Women's Health Line is led by Dr. Paula Graves. And they have recently launched an initiative to identify younger women at higher risk of cancers. It's called GABBI, G-A-B-B-I. It's actually started by a woman who had cancer identified at age 24 named Caitlin Kristin. So that has just been launched at certain OB practices within the Wellstar system. But the real idea there is that people are able to do a risk assessment and then have an online consultation. So you don't have to physically go somewhere. So it's an evolving model, but I think in terms of access to some medical genetics information, it's really what we need to do. We ought to be able to reach people where they are, and so that's really an initiative that I think is excellent. I also want to mention that obviously we're working with Medical College of Georgia. To the other people in the panel next door, our Dean Hess and then President Keene from Augusta University. So one of the things that Georgia needs are more physicians. We have an aging physician population, particularly in medical oncology. So we're partnering with the Medical College of Georgia to have both residents and medical students train in the Atlanta area, as are other institutions. But I think that training the next generation of physicians who are from Georgia, who'll stay in Georgia, is really important. And then Dean Hess also has telemedicine initiatives to reach people really throughout Georgia. And I think we're going to have to leverage that technology. We have areas of the state that it's difficult to get to even a relatively say medium-sized city to get to secondary or tertiary health care. So that outreach is really being done. And I want to mention one last thing. It's essentially a venture capital effort by Wellstar called Catalyst by Wellstar, led by Dr. Hank Capps. And that's trying to leverage medical knowledge and resources together to really identify young entrepreneurs, companies that may change healthcare and really drive innovation. So that's part of where the support of the platform called GABBI is coming from. So I think all these initiatives and also working together with multiple health systems, our goal is really to help people in Georgia and get care to people who need it. So I'll stop there, but thank you.
Thank you, Dr. McCune. So my next question is for Lynn, and I think this is really the elephant in the room. So what do we know about why younger women are developing cancer?
Hi. Well, thank you very much, Dr. Higgins. I want to say, for those who don't know what Georgia Core is, we're a statewide nonprofit that works to reduce the burden of cancer through research, education, and advocacy. And so we are a convener and a connector. We work with all health systems throughout the state. We are ecumenical. We are Switzerland, and we want to make sure that Georgians are just getting the best cancer care that they can get. And so I wanted to start with that. I also want to say one thing that Dr. Higgins didn't say about me when she introduced me is I'm a 3-time cancer survivor. I had thyroid cancer when I was 36. I was diagnosed with breast cancer at 41, and I was diagnosed with chronic myeloid leukemia 10 years later at 51. Luckily, I am cancer-free today, and it's because of clinical trials and because of the incredible care we have right here in Georgia with physicians just like those here on the panel. I am not a physician, so I always like to say that. But what I want to say, thank you so much for the question. And, you know, there's research happening as to why, but honestly, we don't have a lot of answers as to why, and that is difficult to say, but we do have ways to prevent cancer, and so we need to talk about that. First, I do want to tag on to Dr. Bruno's statistics, and she's absolutely right. So the American Cancer Association comes out every year with an incredible guide on facts and figures surrounding cancer, and it has mortality rates, it has incidence rates, it has trends, and the trend it showed this year that is so concerning is that younger women are particularly having more cancer diagnoses. So the statistics she used that women are 82% more likely to be diagnosed with cancer under 50 years old than men are. And that is a startling statistic that we really need to pay attention to. We also know that for women ages 20 to 39, cancer is the largest disease killer of those women. And so we look at women, especially if you look at breast cancer, it's so concerning right now that women in their 20s are being diagnosed with and dying of breast cancer. That is almost unheard of in years before, but it's happening, and we need to pay attention to that. Also, lung cancer, we know that women are getting that. So lung cancer is actually the leading cancer killer in the United States for both men and women. And so there are so many women who've never smoked, men who've never smoked, but they are getting lung cancer. And we'll talk about prevention in just a minute. I want to talk about colorectal cancer because Georgia Core has a campaign right now. You're going to start seeing it all over Georgia. It's called Weird Looking Stools, and it's a play on the word stool, which is your poop. Let's be sure to talk about that and to make sure people, especially 25 to 45, understand the signs and symptoms of colorectal cancer because more people under 50 are dying. And by 2030, colorectal cancer is actually going to be the leading cancer killer of people under 50 years old. So we want people in Georgia to know the signs and symptoms, and we thank the General Assembly for appropriating money for this campaign. And then the last one I'm going to talk about is cervical cancer. Cervical cancer that's the one that almost hurts the most because we have prevention for that. We have the HPV vaccine, but women 30 to 44 are still being diagnosed. More women are still being diagnosed right now with cervical cancer. I can't express enough how, and I know I'm talking to a room full of people who are knowledgeable about health, but please talk to your family and your friends about getting children especially vaccinated. You can start at 9 years old, up to 12 years old, but you can actually, insurance will cover it up to 26 years old. Even if you are sexually active, you can go ahead and get the HPV vaccine if you haven't, up until insurance generally will cover it up to age 26. And so it's an incredibly important preventive measure. And so that's one area of prevention. And also, we need to be honest about how we treat our bodies. Is it obesity that or food addiction, something we're having too much weight on our body? That can cause cancer. Processed foods that we eat. We're hearing a lot about that in the news right now. And absolutely, Americans eat a lot of processed food and a lot of processed meats. The processed meats can contribute to colorectal cancer. So we need to make sure we look at that. Sedentary lifestyle, we got to get off the couch. I have to tell you, my mom died at 70 years old of a massive heart attack. She sat on the couch every day and night knitting. She wouldn't get up, she wouldn't move. And I saw it myself, and it's so incredibly important to make sure that everyone, but especially women that are at the higher risk of cancer, are up and active. And then lastly, I'll talk about alcohol. Alcohol, more and more studies are coming out showing that connection between alcohol and cancer, and we need to pay attention to that. Moderately drinking alcohol shouldn't be a problem, but especially for my ladies, if you're going home every night drinking 2 glasses of wine to relax, you need to think about that. I know a lot of women who do that, and I get it. I totally understand it, but you've got to think about your overall alcohol consumption and how that's adding to your risk for cancer.
Buy your license tags. They help support Georgia Core.
Thank
and,
you.
and Lynn's one of our favorite people. She helps big health systems work together in Georgia.
Oh.
It's a great organization.
Thank you so much. He is one of our board members, which I'm grateful for. But we do have 2 license plates, a breast cancer license plate and a all cancer license plate. If you go get that for your car, Georgia Core gets $22 from the sale or renewal of that tag, and then we give it to health systems and nonprofits around the state to provide women who don't have insurance and men on the prostate, colorectal, and lung cancer free screenings. Thank you.
Thank you, Lynn, for your comments. So my 12 and 14-year-old boys have both received their HPV vaccines, so not only does it fight against cervical cancer, but also oropharyngeal cancers. So I think that is a really great point. So, Dr. Bruno, my next question is around supportive care. And we talked about supportive care really treating the whole person, the whole woman, everything that she's going through during her cancer diagnosis. And I think that many institutions have elements of supportive care, but how do we expand upon it? How do we pull it all together? And how do we tailor it for younger women?
Yes, so it's a terrific question. One that addresses the fact that we really need to be worried about delivering patient-centric care. Women, when they get diagnosed with cancer at a younger age, they get diagnosed with this catastrophic disease when they are just starting to thrive and plan and build their families, their careers, and then there is cancer. And of course, because the complexity of the lives that they lead is such, there will be many disruptions and issues that will arise that will need to be met and supported so they can thrive after their diagnosis, not just survive, right? So that's something that we need to keep in mind. The supportive care approach is really not a non-science. It's really scientific. We have evidence-based. We have a comprehensive, multi-pronged approach to supportive care that detects problems, prevents problems, and treats problems as they arise throughout the continuum of cancer diagnosis, treatment, and survivorship in order to allow for individuals to navigate the situation the best way possible. And it's very important to have a team that provides active listening to that individual's needs, because even though we're lumping everyone here together, younger females under age 50, the needs are certainly individualized, and we need to be actively listening to identify the points of pressure that we need to provide relief for. And there is a discipline called supportive oncology, supportive medicine, but it's not only about having that discipline acting with your patient, of course provided reimbursement as well, but you need other disciplines that also provide supportive care to those individuals, going from behavioral health, from nutrition, naturopathic services, spiritual guidance, social services, financial guidance. All of that can be thrown into the basket of supportive care. And women, younger female patients, will need those services in order to have their needs met, right? The needs are many, going from, of course, somatic, physical needs that stem from the diagnosis itself, the impact of the cancer in the body, but also the treatments and the side effects that they end up producing, making sure that we're recognizing the financial constraints, the need to go back to the job, body image, the pressures at home and the community that they need to meet. So all of those specific needs to be addressed in this patient-centric delivery. And I'm fortunate enough to work at an institution that really takes the patient-centric approach for cancer care delivery seriously. And to be able to count with the help of those disciplines and colleagues that work in those disciplines that are able to see patients same day, if the need arises, and start troubleshooting the needs before they become major problems.
Yeah, those are really great points. I think the other thing to add about supportive care is that one of the things that I think women really need is connection. And connecting with other patients that have gone through what they're going through can be of the utmost help. At City of Hope, we have 2 women that just went through breast cancer diagnosis and treatment together. And they actually started a podcast, and they called it Booby Banter. And they were just interviewed by Fox News yesterday, and it aired yesterday evening at 5:30. And you could just tell that having each other, having somebody going through what you're going through at the same time, being able to bounce questions off each other, and just having somebody that understands each day that what you're going through is so helpful. And Lynn, you probably can speak to that being a cancer patient.
Absolutely. I talk about, I was one of those people who was like, oh, no, I got this. I'm fine. And didn't want people to see my weakness, to see what I was going through. You can't do that. And you really need help of friends and family and professionals who understand. I've seen my share of therapists and talk through. Fear of recurrence is something that is with me every single day. If I have a backache, I'm sure I have multiple myeloma. If I have a headache, I'm sure I have a brain tumor. And that's not even funny. It's just my life. It's just how. So there are different issues that you need to deal with. And I did want to say one thing about, give our props to our Georgia General Assembly. They passed a law last year, and the governor signed it for fertility preservation. It is incredibly important for our families to know that they have fertility preservation rights in our state. And so if they're going through cancer care, lupus care, there are several diseases that were in the language of the law, but they can get insurance to cover fertility preservation. And we're very fortunate in Georgia that our legislators listened to that and took action on that.
Great. So one thing that I think comes up a lot with our younger patients, we hear anecdotally in our offices that a woman has had a symptom, let's say a cough, for many, many months, and she's gone to her primary care doctor, and she was put off and went to urgent care and kind of just circled through a lot of different doctors, and cancer was never part of any sort of differential. And it took many months, maybe 9 months, 10 months before they were diagnosed. And we know that with a cancer diagnosis, time is very, very important. And my question to all of our panelists is, what would you recommend to a woman if she feels like her symptoms are not being taken seriously?
Well, I just saw a patient yesterday at the office. I'm a thoracic oncologist, so my focus of practice is really lung cancer. And I saw a 41-year-old female come in yesterday to the office that has been diagnosed with stage 4 lung cancer and really never smoked. I mean, her smoking history is not a serious one. And because of her age and the fact that she really never smoked, she doesn't meet criteria for screening for lung cancer. We have low-dose screening CAT scans are approved and paid by insurances for individuals who are aged 50 to 80 years old, who have smoked at least a pack of cigarettes per day for 20 years or half a pack for 40 years. And she didn't meet those criteria, right? So came into the office yesterday and telling me the history of the discovery of having cancer, having COVID, developing a cough that never recovered, going from emergency room to emergency room, having chest x-rays that were showing a shadow in the lung that was felt to be pneumonia, then having a pleural effusion, fluid around the lung that it was felt to be related to the pneumonia, let's give you more antibiotics and so on, until finally she underwent a TAP, a thoracentesis. They They put a needle in the chest, and they were able to drain that fluid, and they saw adenocarcinoma cells in the fluid, and she was diagnosed with lung cancer. And the shock and the disbelief, how can this be true, and coming for a second opinion to make sure that her diagnosis, treatment, and management is the best possible, that she's in agreement with that. So I think it's really important to, first of all, understand the risks are there. For breast cancer, we're way ahead. We're really ahead in terms of understanding risk. But for lung cancer, we're still really at the very early stages. We don't know really why we're seeing this rise in cancer rates in younger females. Does it have to do with radon exposure? We should know that 1 in 5 houses in Georgia actually has an acceptable radon levels. We need to check our houses and make sure that we are mitigating radon exposure inside of our homes for ourselves, for our children. We know that secondhand smoke, of course, people who are exposed to secondhand smoking have 2x, 3 times the likelihood of developing lung cancer. We know that probably environmental pollution plays a major role right now to the increasing rates that we're seeing, but we need to be aware that tobacco exposure is no longer the issue that really only drives lung cancer. I mean, the typical lung cancer patient, the older man who has smoked a lot, that's no longer the case. So if you have a condition and that's not going away, a cough, a respiratory symptom that is not really going away with the first round of antibiotics, request more. Request more imaging. Sometimes just chest x-rays won't do. You need a CAT scan to better evaluate your chest. And be insistent about it and seek second opinions. I mean, we're always giving second opinions at City of Hope and, of course, at Wellstar. And we really need to take charge of our health and make sure that we seek answers for our potential symptoms that may be the herald of a cancer diagnosis.
Yeah, Lynn and Steve, do you have anything to add to that?
Yeah, I'm going to say physicians need to listen more. It's easy to say a person needs to be their own advocate, which is great. But I think in the course of a very busy day, we have to take a step back and listen to people. And it's easy to say, well, maybe this person is, sort of doctor shopping or something. But I think just taking a moment to really listen. I think the best thing people can do is have a relationship with a primary care doctor where you build a sense of trust that goes both ways, that person is more likely to listen and say, hey, this is not what this person usually says, that they have a problem and I need to check it out more. So personal advocacy is great, but I do think physicians and providers need to listen more to people.
And I would say for primary care physicians, the burden on them is great. What they have to do to care for their patients is great. But I hear from people all the time, especially young women, that when they go and they talk to their doctor about a symptom or a problem, they say, oh, you're young, you're healthy, you can't have cancer. I can't tell you how many times I've heard that story. I have a 37-year-old woman, was diagnosed last year, a friend of mine, Georgia Tech graduate, incredible woman, and she had blood in her stool and stomach abdominal pain for about a year. And she talked to her doctor, and he said, oh, you just had a baby a year ago. You probably have hemorrhoids. Don't worry about it. You're young and healthy. She had stage 3 rectal cancer. And I think if your doctor's not listening to you, then you need to take action and find someone who will do the test and to make sure that you're okay.
Thanks for that. So my last question that I want to pose to the panel, so I think we're all here very passionate about clinical research, and we've seen just the outstanding progress that we've made in cancer treatments with clinical research. I think for young women, when you approach a woman who has this cancer diagnosis, you've gotten over the shock of why me, why is this happening, and then a doctor presents a clinical trial. I think there's sort of an immediate tendency to say, no, I just want the standard of care. It's tried and true. I can't risk not being cured because I have so much to live for, my family, and this, that, and the other. So I guess I just wanted to ask, how do we think that research can help the younger female population? I know that's a broad question, but what are your thoughts?
Yes, so I think it's, first of all, I'm passionate about clinical research. As a medical oncologist, I've seen tremendous growth in terms of effective therapies being developed, tested, and delivered to the public through clinical trials. For lung cancer, it's been astonishing, the pace of evolution over the last 20 years. And that benefits all populations. The amount of targeted therapies that have been developed that are highly effective and have much less side effects than cytotoxic chemotherapy is unbelievable. We have now 9 subpopulations of non-small cell lung cancer that we treat differently, depending on the genetic abnormality that the tumor harbors. And how did we come about that? Through clinical research, right? So I must say that, first of all, at our practice, clinical research is considered standard of care. Standard of care is for you to offer a trial to the patient and make sure that you check eligibility for that study and discuss with the patient the potential trial. Trials nowadays are very well informed in the sense that there's a lot of science that takes place before we start running clinical trials. We understand much better biology, behavior of cancer, molecular subtypes now than we did before. So when drugs hit the phase 1 and 2 phase of drug development, oftentimes they're poised to be winners against the standard of care. And when you join a clinical trial, it's not only about getting the winning drug, it's also about getting a type of care that is different from standard of care. So if you participated in a clinical trial before, you probably know that you get access to a 24/7 landline that will pick up the phone at any given time. What's the problem? What's going on with you? And if you are participating in a trial, addressing symptoms right away, assessing them, grading them, making those modifications in a very restricted protocol. So there are a lot of perks in participating in clinical trial. At City of Hope, we actually we were able to have patients enrolled in a very important trial in breast cancer, the I-SPY2 trial, which was a multi-center, multi-cohort study looking at molecular subtypes of breast cancer and how to best select therapies for those individuals before they had surgery, and see if we could increase the rates of what we call pathologic complete response. So you take a medication before having surgery. By the time you have surgery, the cancer is gone, basically. And it was so nice to see that actually the average age of individuals that enrolled in that trial was less than 50. So really benefited younger females. And the rates of pathologic complete response using that molecular informed stratification selection of medication was really great. I myself have done research, and we just published actually last month, trying to develop patterns of testing for individuals with lung cancer for molecular subtypes that are treated with targeted therapies, decreasing the time that it needs for us to get those molecular test results by using a navigator that looks at the tissue after the biopsy is done, and detecting higher rates of actionable genomic alterations, which really is what drives a vast number of lung cancer in younger females. So we are all invested in clinical research. We need to take it seriously, and then again, take it as the consideration that really should be a standard of care for you to discuss clinical trials, should be a standard for the patient as well to demand, hearing about clinical trials and considering seriously participating in one if there is availability.
I'll just say very briefly, I think it's a matter of establishing trust between the patient and the physician so that they feel that they're not being signed up for something, but that the physician is offering them what is really the best care for them. It's also building trust in the community. I will say our cancer research program is one of 14 in the country, designated by Merck as a diversity center of excellence. We have done outreach activities like a breast cancer day at a predominantly African-American church. It's about reaching out and establishing trust so that people don't feel like they are an experiment, that they feel like their doctor is trying to do the best thing for them. And part of what all our institutions do is to try to bring clinical trials to the community so that people who can't drive to downtown Atlanta or for some of our outlying areas can't drive to Birmingham to UAB, that they do have access to cutting-edge trials. So we've had the first U.S. patient on some trials in our Carrollton office, which is, it's kind of in the middle of nowhere, but they do have access to some of the best care in the country through clinical research.
I'll tell very quickly. I know we're about out of time. We have a program called the Georgia Cancer Trial Finder Program, where a physician or a patient or a caregiver can call our navigator and say, we have this disease, this tumor marker, and then they can look for clinical trials here in Georgia for that person. But we have one of the members of the advisory board for that is a woman named Michelle, who is in her 40s, and she's a breast cancer survivor. And what she told me one time just hit me so hard. And she said, I said, why did you participate in a clinical trial? She said, my mom told me never to take someone else's medicine. But if people like me don't take part in clinical trials, how will we know if that's the right medicine for me? And that just gives me chills to this day. We need people who will take part to understand how it affects younger people, how it affects African Americans and other races. We need a diversity of people in clinical trials.
Wonderful. Well, we are out of time. Thank you so much to our outstanding speakers. Thank you to Health Connect South.